Hello, everyone, and welcome to On the Pulse. I'm excited to be here today. I'm Courtney Jordan Baechler. I'm one of our cardiologists with the Minneapolis Heart Institute Foundation and have the great opportunity to talk about pregnancy and talk a little bit more about some of the complications that can arise during pregnancy and how that relates to heart disease. So, as you can see, you're going to learn all sorts of exciting news about maternal health and why it matters and how we can best support you going forward. So, many of you have probably heard that sometimes we think of pregnancy itself as the first stress test. Stress tests are something we do in cardiology where we're assessing how well your heart does with either exercise or sometimes we'll do a chemical stress test. In this case, we're actually talking about pregnancy being just that. Part of that is because the volume shift that happens as we support growing a baby that happens and how much stress that actually puts in the heart. We have now since discovered that really this is very much like a stress test for our heart. One of this slide here you can see talks a lot about high blood pressure, otherwise known as hypertension, and that overall impact on the development of subsequent heart disease. So you can see chronic high blood pressure accounts for one half to two-thirds of the overall extra risk of pregnancy that can develop in these disorders that we call hypertensive disorders of pregnancy. So there's a few different ones that we're going to talk about throughout this talk and what they can then subsequently do to increase your risk of coronary artery disease, which you can see depicted here. That's the plaque or blockages that can develop. Heart failure, which is when that pump or the left ventricle doesn't work. Narrowing of the aortic valve, otherwise known as aortic stenosis, and mitral regurgitation, which is when that mitral valve has backwards blood flow. Instead of just going straight into the left ventricle, it's going backwards into the left atrium. So all of these have been associated with worst outcomes if people develop high blood pressure during pregnancy. And one of the things that I want to emphasize here with the statistic that we started out is that about a third of women who have high blood pressure before pregnancy actually starts aren't getting adequate treatment or getting treated with antihypertensive medications. So we have a lot of work to do in prevention overall. And you can see why we call pregnancy sort of the first stress test, if you will, because so we know that there are some risk factors that put you at risk for developing this overall. And one of those is sedentary behavior. So less than 5% of our entire country gets 30 minutes of movement a day. And this is still critical during pregnancy. So it doesn't mean that we're suggesting you go out and do hot yoga or something really extreme during pregnancy, but walking around the block, getting fresh air, going on a bike ride, those types of activities are really important to decrease your risk of developing high blood pressure during pregnancy or having worse high blood pressure during pregnancy. So these are some of those risk factors. Then we talk a little bit about what happens with the placenta and having some potential abnormal vasculature during pregnancy that can put you at increased risk of having what we call an ApoE or an adverse pregnancy outcome. That then can turn into during pregnancy and right afterwards abnormal heart mechanics or physiology. Abnormal endothelial dysfunction. The endothelial is the inside of the heart artery, puts you at high risk of having a heart attack. And then finally, loss of arterial compliance, which again makes it so that the blood vessels can change shape really easily. When we lose that, we develop high blood pressure, and ultimately we can then have overt what we call cardiovascular disease. So here's just a little scheme, again, showing some of the things that we believe ultimately put you at risk of developing cardiovascular disease during pregnancy and then subsequently afterwards. So some of those pre-existing cardiovascular risk factors, high blood pressure before you're pregnant, obesity, poor nutrition, extra alcohol use, tobacco use, or having a sedentary or immobile lifestyle. You can have genetic risks that then increase your risk of these adverse outcomes. Inflammation in the mom, so different types of rheumatoid arthritis, different types of inflammatory diseases can increase inflammation throughout our body. We can get ischemia in the placenta, like we talked about, so that nutritional supply to the baby can have hard some problems getting enough blood flow. You can have vascular dysfunction. So, again, problems with the arteries primarily. And then again, we can see that sometimes people don't adapt well to these pregnancy outcomes. That then produces cardiovascular consequences leading to long-term thickness of that heart muscle, which again is going to produce high blood pressure, heart failure, decreased arterial compliance, endothelial dysfunction, putting you at risk for blockages, and then finally, premature risk of ischemic heart disease, plaque, and stroke. So here's another way that we can look again at some of these things that we're talking about and have specifically for women a better way to look overall at your total risk of ultimately developing cardiovascular disease long term. So some of the things that you've heard me mention, so lupus, we know lupus increases your risk of ultimately developing ischemic heart disease 3 times higher. Gestational diabetes, so high blood sugar that develops during pregnancy, increases your risk of subsequently developing type 2 diabetes long term, fourfold higher. And that then increases your risk of heart attack by up to 60%. High blood pressure in pregnancy. So we're talking both about preeclampsia, which is more than just high blood pressure. It's also having protein in the urine. You can get systemic other signs such as swollen feet, can increase your risk of developing ischemic heart disease threefold. Early menopause, in this case, we're talking about menopause before age 40, can increase your risk of developing ischemic heart disease. And then depression, we know, is much more common in women and also doubles your risk of ischemic heart disease. So on the right side, we have all sorts of other risk factors. So high cholesterol, unfortunately, the data shows us that women are less likely, if they have high cholesterol, to have it at goal level, being on either a medication treatment or lifestyle treatment. Of the women who have high blood pressure, 80% of women over age 75 have high blood pressure, and only about a third of women actually have their blood pressure well controlled. Like we talked about diabetes, it puts women at higher risks. Smoking increases your risk by 25%. Obesity also increases our risk 64% compared to about 46% for women who have a weight that's controlled. And then inactivity increases that risk about 25%. So lots and lots of things, along with family history, which is definitely a piece of it. You can see it can increase your risk as much as 2 times, but it doesn't tell the whole story. There's lots of things that we as a society, as clinicians, as sisters, daughters, friends can help each other out at better controlling these risk factors. And here's just another way to look at that down below. So this is one of the ways that we've looked at, again, the risk of developing cardiovascular disease. In this case, that's being described as either stroke or blockages in the coronary arteries or those arteries that serve blood to our heart. And you can see hypertensive disorders of pregnancies, which include both gestational hypertension, which again is simply high blood pressure that develops during pregnancy, or preeclampsia, which is that more complicated condition that includes other things besides just high blood pressure, such as the protein in the urine, et cetera, increases overall that risk substantially of developing cardiovascular disease later in life, as high as 1.7 fold in those with preeclampsia. And then when we break it down, it's really that blockages in the arteries and the coronary arteries that's significantly high with preeclampsia, 2.2 fold higher in those that had preeclampsia, whereas stroke was more common in those that had gestational hypertension. So here's another diagram looking at hypertension, cardiovascular disease, ischemic heart disease, blockages in the arteries, strokes, heart failure, and diabetes. And then you can see on the left side here, looking at preeclampsia, gestational hypertension, gestational diabetes, preterm birth, which is also a risk factor for developing cardiovascular disease later, as well as small for gestational age. So a smaller size baby overall. And where you see the highest risk, again, is with, in this case, gestational diabetes and the risk of ischemic heart disease, with that relative risk being overall about 2.1. Also, gestational hypertension and diabetes, increasing your risk or relative risk by about 2.06. Preeclampsia and that risk of stroke quite high at almost threefold. So again, overall substantial increase in risk. And here's another way where we're breaking down preeclampsia, gestational hypertension, and or compared to a pregnancy with normal blood pressure. And you can see how this risk is much higher in both of those conditions throughout the lifespan of the mom. So this is looking at years since first birth. So again, this is going to be if you had a child at 30, this is 31, this is 35, 40, and so on. You can see how that risk does increase later in life as well. So things that we can think about before you're ever pregnant. So, obesity, we talked about. We usually, in medical terms, define that by BMI or body mass index. That's height over weight squared. You can calculate that online. 18 to 25 is normal. I also think that we have a challenge at what is actually normal in terms of weight gain during pregnancy. So that's something that you could have further conversation with your obstetrician or family practice doctor. High blood pressure and then high cholesterol, as well as glucose intolerance. So people who've not gotten full-blown diabetes yet, but have what we called an impaired fasting blood sugar or a high blood glucose level. All of those things are then going to make it difficult for that vasculature to work well. The endothelium, like we talked about, is going to put you at higher risk for placental dysfunction, as well as inflammation. These are the things that develop during pregnancy: preeclampsia, gestational diabetes, those small for gestational age, as well as preterm delivery. And then afterwards, further risk factors that we can see that are basically unmasked during that can happen: more environmental and lifestyle factors, tobacco use, sedentary lifestyle, poor nutrition, high stress, untreated mental health, is going to then increase these risk factors: high blood pressure, diabetes, obesity, metabolic syndrome, which is really the combination of 3 out of 5 risk factors of waist circumference, cholesterol, blood sugar, and blood pressure, and then ultimately developing that cardiovascular risk. I will just emphasize, I graduated my medical training for cardiology in 2011. As you guys are aware, it's 2024 now. So these these things were not talked about the same way during our training as they are now. to me, as a former mathematician, it makes logical sense that pregnancy is, in fact, this true stress test for our heart. I'm glad that because of the research that's been done at places like the Heart Institute Foundation, we're realizing that we really, particularly for women, need to focus on these things earlier during pregnancy and before, so that we don't see some of these disparities that we see in women's heart disease long term. But I would just emphasize how new so much of this is, and how much more work needs to be done. And you can just see here with the plus signs showing the overall risk, where again, small for gestational age, preterm delivery, definitely there is some increased risk, but where we really see these substantially increase is in both gestational hypertension and preeclampsia. So we have to do better is the bottom line here. We know that established cardiovascular disease risk factors arising after pregnancy explain about 84% of the increased risk of cardiovascular disease that we see in those two conditions, gestational hypertension and preeclampsia being 57% of these. So we have to be screening before people are ever pregnant for high blood pressure, high cholesterol, type 2 diabetes, overweight and obesity, both before and after pregnancy. As we know in studies that we've done at the Heart Institute Foundation, many women don't get screened after pregnancy to further lower their risk long term. This is something that we put together here at the Heart Institute Foundation, where you can see different risks that we've talked about. We talked about tobacco. Tobacco with birth control pill increases your risk of developing heart disease substantially. Pregnancy, when we don't lose weight after those pregnancies, so we see that in multiple pregnancies, that sometimes that weight just keeps building up. That LDL or bad cholesterol not being treated, the autoimmune disorders like we talked about, lupus, rheumatoid arthritis, that early menopause, pregnancy conditions. We talked about low birth weight, depression, we've also talked about. And then we do know the association with cancer treatment and subsequently developing cardiovascular disease. So this is another thing that we want to be having conversations about. None of these things have to be scary, but they have to be things that we talk to, not just with our friends, but also with experienced clinicians who know how to best treat women with these conditions. And then finally, type 2 diabetes and high blood pressure. So again, I think one thing that we want to talk about is many of us get our care solely through our obstetricians and gynecologists. And I completely appreciate that. But many obstetricians and gynecologists are not trained in these cardiovascular risk factors. And so there has to be a lot more collaboration. And in this case, the experts, the American Heart Association and the American College of Obstetricians and Gynecologists, is saying, how do we work better to get women what they need? And you can see here that new prevention guidelines are being developed with that, and also more referrals for these specialists, whether it's a cardiologist that you need to see or an internist or family medicine doctor with more specific training here. We have developed some educational materials both for clinicians and also for patients to really work on how we can keep ourselves most healthy and most educated on these topics. And here's just a few things. I know people always find cardiovascular disease complicated. Mammograms screen for breast cancer, and people always wish there was just one thing you could do for cardiovascular disease. And it's not as easy, but here are a few numbers for you to keep in mind. Got to know your blood pressure. The bottom line is it should be less than 120 over 80, and you should have that checked within 6 to 12 months postpartum and earlier if you developed any of those conditions that we talked about. Cholesterol, you should have that tracked 12 months, or excuse me, 12 weeks after you've delivered or after you are done nursing if you are going to be nursing. It can be tricky because we don't use a lot of cholesterol medications during pregnancy or while you're nursing, but again, you should at least know what these numbers are. As it relates to diabetes, 4 to 12 weeks after, if you had gestational diabetes, is critical that we get that risk reduced. And then obesity, like we talked about, at least annually, you should have that checked. Tobacco use, we want to be making sure that you're not smoking or you're getting the help you need to quit early. And then nutrition is something that so often gets missed. The American Heart Association just put out the number one cause of premature cardiovascular disease is our nutrition. So we have work to do. We talked a lot about blood pressure. Folks get confused. There's early signs, late signs, but the bottom line, if you're under 70, 120 over 80 is normal. Sometimes we have high blood pressure here and there for certain reasons. We're stressed, we've been running, your blood pressure goes up with activity. But if it is over 120, over 80, over and over and over, we need to get that treated. And then you can see again, here's just some overall steps that we've talked lots about things to look for in terms of conditions, and then specific ways with both lifestyle and pharmacologic treatment, if appropriate, to manage your blood pressure, control your cholesterol, reduce that blood sugar, and then the lifestyle pieces, staying active, eating a strong nutrition that supports our bodies in healthy ways and not smoking. I want to emphasize if we could do nothing else, lowering blood pressure would make a big difference in our cardiovascular outcomes long term and specifically in the health of our moms during pregnancy. You can see here that really only about half of people with high blood pressure have their blood pressure under control, and that's less for women. So again, things just to think about. Obesity, we talked about. Untreated sleep apnea is going to make a big difference with blood pressure and weight loss. Nutrition, movement, stress, and just thinking through the vast referral options that we have, because we really do have quite a few groups of experts between primary care, internal medicine, weight management, and preventative cardiologists. People always have questions about diets. On the left side, you have the anti-inflammatory diet, which is a tremendous way to eat. Great, truly for nearly all conditions. And then the Mediterranean diet on the right, which is another nutritional platform that has evidence to show improvement in cardiovascular outcomes long term. So with that, I'm going to answer some questions that I know John has waiting, but I hope you've enjoyed this presentation.
All right. Well, thank you to Dr. Jordan Baechler for your time and expertise during today's On the Pulse session. Outstanding presentation as always. And hello, everyone. My name is John Rickert. Just going to be jumping on here to help facilitate the Q&A as I'm the virtual event lead here at the Minneapolis Heart Institute Foundation. So the questions that we have prepared today were all submitted prior via social media, registration, and other outlets. So thank you to our registrants who did submit a question. However, please also feel free to add additional questions using the Q&A pod, which is going to be located at the bottom of your Zoom screen, as these could be addressed in a future On the Pulse session. All right, so the first question that we have, this attendee asks, what are the chances of complications or recurrence in future pregnancies if I've had a cardiovascular issue in a previous pregnancy?
Well, that's a great question. It really depends on the condition overall, but definitely there is an increased chance with most conditions that that will happen or has the potential to happen in further pregnancies. So having a conversation with definitely your obstetrician and potentially a cardiologist, if you've seen one, that is something that we routinely do to number one, minimize the risk of that happening, and number two, be ready, sort of ammunition loaded and ready to go to make sure you have the best outcome long term.
Yeah, absolutely, and certainly a very important piece of information. So, On a similar line, you spoke briefly about genetics throughout your talk at various points. So this attendee is asking, what are the chances of passing on a heart condition to your baby?
Yeah, great question. Totally depends on the genetic condition itself. We do have genetic counselors available, and so that would be something that if there was any concern, you could certainly meet with one of our genetic counselors. But sometimes it's just a rare, once sort of an opportunity unfortunate outcome and not something that you need to be concerned about. And there's also all sorts of advanced imaging and things that we can do these days to screen both the baby and have those conversations with our genetic counselor. So definitely information available.
Absolutely, and thank you so much for that. So,
Hmm.
the next two questions that we have essentially have to do with having a cardiovascular issue or having a diagnosed cardiovascular disease, and either medication safety or anesthesia or pain management throughout the birthing process. So, the first question, this attendee is asking, if I am a patient who is pregnant with a history of cardiovascular disease, how do I know if a medication is safe for me?
Yeah, so that really important question about medication safety, I would always ask your doctor because they're very different. The way things are metabolized, whether or not they're safe for both you as the mom and your baby, are really critical. There's lots of drugs that we don't use in pregnancy that we would otherwise use for the mom. So always ask your doctor. Usually in this case, often your obstetrician about what's safe before taking things that are over the counter or anything that was prescribed, just in case someone didn't know you were pregnant.
Absolutely, and I appreciate that insight. So the next question is essentially just taking that one step further. This attendee is asking, what are the potential risks of anesthesia or pain management options during labor and delivery with my heart condition?
Yeah, so it depends on the heart condition, but that is one that, again, we have a great maternal cardiovascular program here. So there's a joint conversation between the obstetricians and the cardiologists about the best way to manage your pain and also to have you deliver. Interestingly, sometimes, not always, but sometimes C-sections or a surgical operation is the preferred way because of the control, in that case, of your blood pressure, your heart rate that we can have with certain types of anesthesia and pain control that way. Again, we only go that route if we really feel it's the best from a safety perspective. But um, the nice thing to know is that you don't need to be in pain, that there are safe ways for both you and your baby to have a optimal outcome. So, but it does need to involve the physicians in this case to make that decision.
Yeah, well, that's great. And again, thank you so much for the insight and that information. So let's see here. We just had a few left, and the next question has to do with managing stress and anxiety. And this attendee is asking, how can I manage stress and anxiety related to my cardiovascular condition and pregnancy? Do you have any insight into that?
Yeah, great question. So we do know that in general, for our society, stress and anxiety continues to go up, and it is an treated need for many people, women in particular, and in pregnancy. So there are all sorts of lifestyle options to start with, right? So adequate sleep. Sleep is really, really, really important to help our body function well and to make sure those neurohormones are optimally being produced that help produce calm, that help produce happiness. So that's going to be a critical place. Meditation, yoga, exercise, what we're feeding our body nutritionally. All of those things give our body the building blocks to produce calm. Most of those things, I'm thinking specifically in yoga, are going to be safe during pregnancy. There are some, intense heat and different things that we wouldn't advise during pregnancy, but overall, the breathing exercises, lots of data on the impact that can 5 to 10 minutes can have to help us feel calm. Music therapy, there's so many great ways to help our body through pregnancy. Then I want to emphasize that There is also a role for talk therapy, psychotherapy, and medications. There's many medications that are very safe for mental health during pregnancy. So we actually have lots of tools for this, but unfortunately, there's often a stigma that's associated with that. And I would just emphasize the number one long-term outcome for the health of babies is the health of the mom. And so while dads are critical to this equation, it takes healthy moms to have healthy babies, and having healthy brains is a critical place to be. So no shame in getting help to make sure that you have optimal mental health during your pregnancy and afterwards.
Yeah, absolutely. And fantastic response. Thank you so much for that. So let's switch gears a little bit to research. So this question is, are there any upcoming research studies that you're aware of, or any research studies that have recently come out that could impact outcomes of cardiovascular complications during pregnancy?
Yeah, so a couple that we have just done here at the Minneapolis Heart Institute Foundation. So we looked at our own database for some of these complications that we were just talking about, gestational high blood pressure, gestational diabetes, and preeclampsia. And we looked specifically for the women that we saw how many had their risk optimally reduced after pregnancy to make sure, again, that we're doing everything we can to reduce risk long term of developing heart disease. And we saw that we had a lot of work to do, that we were far from perfect. And I think that just speaks to the fact that it takes a village, that we haven't figured it all out. We know that things aren't perfect on our end in terms of delivering. And we also know that probably things aren't perfect on the mom's end, right? I know as a mother of two, that it can be difficult to do a lot of those things right after you've had a kid with a job and everything else. So figuring out that is a big part of what we're trying to do. We just finished another study trying to look specifically at that, where some of the moms that didn't get their risk reduced optimally, we allowed to participate in a research study where we offered free virtual healthcare, trying to eliminate some of those barriers for long-term cardiovascular outcomes. And stay tuned because we'll be publishing that data on how that went. But I think there's a lot more opportunities like that that we're seeing nationally is how do we get these risk factors developed or reduced earlier, recognized earlier, and then appropriate screening again, both before and after with various types of techniques, tools, lifestyle, and medications. So there's this is definitely a hot area for sure.
Absolutely. Well, thank you so much for that, Dr. Jordan Beckler. Let's switch gears just a little bit. Let's just do a few more questions here. The next
Yeah.
question has to do with health equity. And it's a fairly general question, but the question this attendee is asking is, can you please speak to health equity as it relates to cardiovascular complications during pregnancy? Any insight would be appreciated.
Yeah, so unfortunately, the bottom line there is that our health outcomes are worse during pregnancies for our moms of color. And I have the opportunity to sit on our maternal mortality review committee for the Department of Health for the state of Minnesota. And this is unfortunately something that we see over and over. And so we have a lot of work to do throughout every disease process. And this is unfortunately no different here. These disparities exist. There's a lot of work and effort going into this to reduce racist outcomes that we see during clinical care, that we do see in terms of when treatment is received, and ultimately in terms of prevention and subsequent risk reduction later. So I think it's an area that it's going to take all hands on deck. It's going to take educational opportunities like this to help make sure that people know about risk factors, that there's less stigma to get what you need, and that you can hopefully get it in the best culturally relevant way that makes most sense to you as an individual.
100%. And thank you so much for that. Let's end with the question on if someone wants to learn more about cardiovascular complications during pregnancy in general, do you have any insight in terms of resources or if someone does have, a cardiovascular complication during pregnancy and after, any sort of resources or even support groups that you would recommend?
Mm-hmm. Yeah, so I think there's a couple. One on our own Minneapolis Heart Institute Foundation, there's quite a lot of information available specific to women's risks and during pregnancy, before, what you can optimize, and after. And then also would put you in touch with womenheart.org, which is a national organization dedicated to women surviving heart disease. There's a lot on there about prevention, but there's also a lot on there about things that develop in pregnancy and later, and sister support. So there's support groups nationally. There's you can get matched with a local mentor. That way you can become a champion. So there's actually quite a bit out there that's available.
Fantastic.
Yeah.
Well, Dr. Jordan Beckler, are there any final words that you'd like to say to our audience before we sign off?
Not really. I just would emphasize how much opportunity there is to improve these outcomes, that it's going to take all of us, those of us on the clinical side, those of us on the receiving side, and everyone in between. So I think we can do this.
Absolutely. Well, that's all the time that we have for today, folks. A big thank you again to Dr. Jordan Beckler for presenting on this really important topic. And thank you to all of our attendees who joined us this afternoon. We appreciate your participation. Before we sign off, just wanted to mention that our next On the Pulse session is scheduled for June 20th. And this session will feature Dr. Mario Gessel, excuse me, will be presenting on the cardiovascular effects of cold plunges and hydrotherapy. So we will go ahead and add a link to the chat pod now, which you may use to register, and we hope to see you there. So thank you, everyone, and have a great rest of your day.
Thank you.
Thank you.